And then move on to an area in which I have been involved with the World Federation of Medical Education on developing international standards for medical education and how Sri Lanka has responded to that. Move on to there's some disturbance. I don't know what it is.
I think please mute your screens. Mute your mics.
Okay. Banda, you can carry on. Sorry about that. Raja?
Maruf?
Yes. I'm calling Raja. I think you say mute your screen. I think he might have muted his audio. Yeah, just don't mute your audio, please. Everybody else has to do that. Yeah. You can't see the screen at all? Can you see now? Okay. Shall I close it and I'll start it? Yeah, okay. 1 minute, yeah. All right? Still you can't see it. Everybody can see the screen, is it? Hello?
Yes. No.
Okay.
Yes, we can see the front slide, the first slide.
Yeah. So, Raja is not seeing it. That's why. Just 1 minute. Raja? He's gone out. Oh, you got
Raja is missing.
Yeah, I know. Just put that picture in there. Raja? Hello?
He is not in the picture.
I know. He's not on the. He's on the phone. He's trying to connect here. Hello?
This meeting? What is it?
Hello, Raja? Benita, Benita, can you try calling Raja? I'm calling from
I
here.
haven't got his number.
Okay. Shall I give it to you?
Just
401 562 012. He must be trying to connect. Raja is connecting now. He's connected, but he's not yet muted. He's still muted on his Zoom.
Yeah.
Hello.
now he has come.
Ah,
Oh,
yeah.
yeah.
Raja?
Yeah, sorry about that. I don't know what happened.
Ah,
I think you unmuted me also.
no, I didn't. I didn't mute anybody.
Then something happened. I don't know. Maybe got cut off.
That's all right.
Anyway,
Now, okay,
let's
now?
continue from where we left off.
Yes, yes.
Yeah.
Yeah,
Thank
just
you.
a minute. Raja, just a minute. I'll share the screen now. Okay?
Yes.
Can you see now the screen?
Yeah. Yes.
Ah, good.
Good.
Okay.
Well, it is generally thought that the Colombo Medical School is the oldest medical school in Sri Lanka, but this is not correct. The first medical school established was really in 1847 in Manipai, in Jaffna. And it was established by a medical missionary called Dr. Samuel Green. This shows you the second batch of students in Manipai. That medical school educated 62 medical practitioners at the time. And the Manipai Medical School, the site of the Manipai Medical School is now the Manipai Hospital in Jaffna. The Colombo Medical School is really, it opened in 1870 under Governor Robinson in the General Hospital, Colombo. Actually, they say it was in the place where at that time where the female surgical ward was. They opened a medical school there. The first principal was James Lowes, and the second was E.L. Koch, under whom, no, that's not the slide, Maruf, no, not yet.
Yeah, okay.
Under E.L. Koch was the second principal. And if you remember the Colombo Medical School, the clock tower, named after E.L. Koch, the second principal. I don't know whether he was an ancestor of famous Dr. Professor A.C. Koch. He may have been an ancestor, I don't know, but I couldn't find that out. At first, when the Colombo School opened, there were only 3 teachers and 25 male students. They were all male students. It was a 3-year course, and that 3-year course became 4 years in 1873, and then increased to 5 years in 1880. In 1880, therefore, it became a college. The moment it increased to 5 years, it became a college. And in 1887, the first diploma was granted. It was an LMS, a Licentiate of Medicine and Surgery, which was recognized by the General Medical Council in the UK. In 1942, it became the Faculty of Medicine, University of Ceylon, granting the MBBS. And of course, we all know that in 1966, with the separation of the universities, it became the Faculty of Medicine, University of Colombo, separated from the University of Peradeniya and the other Javadpur and other universities. So that's the brief history of the Colombo Medical School. I'd like to now move on into women in medicine. The first female medical student to a medical school in Ceylon was admitted in 1892. And this is the lady, Alice de Boer. That's why she was the first woman licentiate from Colombo. Now, this is very creditable because as even in the UK, there was a reluctance to admit women to medical school. There's a very interesting story which I have documented in my book called Betwixt Isles, which you may have heard of. This is a copy of the book that I published about the Candian prisoners in Mauritius. Now, in that book, I looked at the life of the Candian prisoners, particularly the life of Ahelapola Nilame, who was banished to Mauritius after the British took over the Candian kingdom. Now, when Ahelapola was dying, the doctor who treated him in Mauritius was a Dr. James Barry. And he was the last doctor who treated him, and Ahelapola died in 1829, I think. Barry died subsequently, several years later. And when they did a postmortem, they found that he was really a woman. A woman whose name was, they traced it down to a woman called Margaret Bulkley, who was from Edinburgh. And she masqueraded as a man to get admission to the University of Edinburgh. And she continued to graduate and practice medicine in Scotland, then later in South Africa, and subsequently she came to Mauritius, and she was still going as a man called James Barry. Can I have the next slide, please, Maru? Now that's Dr. James Barry, who treated Ahelapola Mahanilame, and he was really a woman. So that was the admission to the University of Edinburgh was in 1812. And even as late as 1870, women doing medicine were frowned upon by the Royal College of Surgeons in England. So it is creditable that in Sri Lanka, the first woman was really this lady who got admitted in 1892. I looked at the situation in various countries around the world, and it's very variable. For example, when I was working at the Rebben Gulf University in Bahrain, there were more women medical students than male medical students. In Colombo, it was less than in Peradeniya. In Peradeniya, there were more women in medical school. So this is something that we have to be cognizant of, and now I think the number of women entering medical school is increasing. The next slide will show you the situation in Sri Lanka. I'll let you read that. So you can see that in 2015, 60% of the admissions to the Peradeniya Medical School were female. Well, that's very significant. I will now move on to a favorite topic of mine, which is integration. But before that, we have to look at the situation with regard to the departments in medical schools. As knowledge grew in the 20th century, and as technology developed in the 20th century, the departments began to increase tremendously. There was this increase in number. In 1949, for example, there were only 6 departments. Then public health was added. In 51, forensic medicine was added. 51, mind you, forensic medicine was added. And that was just before I entered medical school. In 52, physiology split into 3 departments: physiology, biochemistry, and pharmacology. I entered in medical school in 53, and already the physiology department had split. Pathology had split into pathology, microbiology, and parasitology, and medicine into medicine, pediatrics, and very much later in psychiatry. In fact, some of you may be aware that the late Dr. Channa Vijayasinghe was appointed the foundation professor of psychiatry in 1971. Channa died in September last year. He was a batchmate of mine, and he died in Melbourne, here in Australia. So in 2016, a new department of medical education and humanities was added. And the current total of departments in the Colombo Medical School is 16. So from 49 to 2016, it increased almost threefold the number of departments. Now, this resulted in specialization, of course, and subspecialization. The problem was, as knowledge grew, there was so much of knowledge in the medical field, and each department in the medical school was trying to teach the medical student as though they were going to become a specialist in that discipline. I must say, I have been partly guilty of this too, the way I taught anatomy, as though they were going to become anatomists. Something had to happen. Medical students began to revolt in some countries, like in the US. They began to revolt against this enormous body of knowledge that was being imparted to them in medical school, in undergraduate medical school. So the next thing that happened was really they started looking for new ways in which to compartmentalize this knowledge. And there was a cry in medical education, a cry for relevance in the teaching of medicine. So they began to look for other ways of organizing the curriculum. And in 1952, Case Western Reserve University in Cleveland, Ohio, in the United States, began to organize their curriculum in interdisciplinary committees rather than within the departments. So the responsibility for organizing the curriculum and determining what should be taught was in the hands of interdisciplinary committees. And this was further enhanced in 1968 by some of the pioneering efforts in schools like McMaster, firstly in McMaster in Canada, where they started what is called problem-based learning. I'll come to that shortly. That was copied by Michigan State University, by Maastricht in the Netherlands, and by the University of Newcastle in Australia. Those 3 schools copied this tendency to move into problem-based learning rather than teach within departments. Many other schools copied it later, but it was very slow to take off. And throughout the 20th century, problem-based learning and integrated curricula did not catch on, but towards the end of the century, it improved. Now, what was the Sri Lankan situation with regard to this? In 1974, I had just come back from California after my master's degree in medical education. And the first attempt at integration on a trial basis was undertaken in Pereira. I spearheaded that attack on the curriculum, and we developed a unit called the cell biology unit, which was an interdisciplinary unit, including anatomy, physiology, and biochemistry. That was the first attempt. It lasted for 2 years. After that, it died a natural death. I don't know what happened because I left in 1976 and came to Australia. In 1995, the Colombo Medical School, which some of you are aware of, changed into an integrated curriculum in 4 streams with the judicious use of problems. And this was under the deanship of Professors Nandadasa Kodaguda and Lalita Mendis. Nandadasa Kodaguda followed by Lalita Mendis. 2 teams came out to Sydney to the university, to the department I was working in. And some of you were in that team, as you remember. And they worked on an integrated curriculum with me. I gave them a model. They worked on the gastrointestinal system, I remember. And they went back and tried to teach the other faculty in Colombo as to how to develop an integrated curriculum. And then another team came over, including, I think the second team included some of you in that group, came over and I remember Colvin Gunratna was in that team, and developed the methods for assessment of students in an integrated curriculum. So that was the situation in Colombo. And I can now move on to what integration is. You know, if you bring different parts into a meaningful and relevant whole, in a general sense, that is what integration is in any area. To bring different parts together, not just by adding them together, but by bringing them into a meaningful and relevant whole. In the case of medical education, meaningful means the extent to which the learner can fit whatever he learns to his previous learning, what he has learned before. So if he has learned anatomy before, he can fit that anatomy into the pathology he's learning. That is meaningful learning. Relevant means to what extent is the anatomy that you learn going to be useful to you in what you're going to be doing in the future? What is your goal in the future? I admit a lot of anatomy that was taught was not meaningful, it was not relevant. Sometimes it was not meaningful as well, but often it was not relevant because, for example, when I was teaching anatomy at first, we used to get students to dissect. And if the dissection was poor, as Karunian pointed out earlier, if the dissection was poor, sometimes they were chased and they had to come back for a second signature. But was the dissection the essential part of it, or what you learned from the dissection? Admittedly, dissection was important for someone who was going to become a surgeon, but not everyone was going to become a surgeon. Some were going to be psychiatrists. So why should dissection be the criterion on which students are judged? It was the anatomy that you learned from the dissection which was important. So that's something to remember in not only undergraduate medical education, even in postgraduate medical education. The last point I want to make here is that integrated learning best takes place in an environment which is the same as or resembles as closely as possible the environment in which such learning is applied. If you are learning anatomy, it is best learned in an environment which is the same as the environment in which you're going to apply that learning. What that means is learning anatomy in a clinical context. But the environment does not only refer to the physical environment, it also refers to the psychological environment. What is a doctor doing all the time? A doctor is practicing in the ward or in the OPD or wherever. Right. So that's the physical environment. But what is the psychological environment? The doctor, he or she, is always solving problems.
Go, don't talk.
He's always solving problems. Now, if he's always solving problems, if you learn the basic sciences, say, in the context of solving a problem, then that is likely to be meaningful to the future doctor. So let's move on to the next slide, Maruf. There are two types of integration, horizontal and vertical. Horizontal integration is integration between subjects at the same level, like the basic science subjects or the clinical subjects. Whereas vertical integration is integration between basic sciences and clinical sciences. Now, you can arrange these according to organ systems or topics, or you can arrange them according to problems. Let's go now to what is meant by the next one. Next slide, please. Here is an example of horizontal integration. I'll let you read that. I won't read that out to you. So that is relating structure to function, and that would be an example of integration between subjects at the same level. Here is vertical integration, where subjects at different levels are being integrated. For example, you learn about bones and the function of bones in relation to derangement of function, and so on. As you can see from that chart, that is an example of vertical integration. Can I move to the next slide? Now, problem-based learning is quite different from problem solving. That's important to remember. Problem-based learning actually, problem-centered learning actually started in school, in high school. It was first introduced in high school for students who were learning mathematics. For example, in geometry, if a student knew how to derive the area of a rectangle, which was length into breadth, they were given pieces of card which were in the shape of parallelograms rather than rectangles, and asked to find out what was the area of a parallelogram. Now they hadn't learned the geometrical theorem about the areas of parallelograms, but they had learned the area of a rectangle. So now they had to apply their knowledge of the area of a rectangle to work out the area of a parallelogram. So they played around with these cards, and they, as you can see in the second diagram there, they cut a part of that, fitted that part into the missing part here. And in the third diagram, you see they have fitted that and they have converted that parallelogram into a rectangle. But now they know the area of a rectangle. The area of a rectangle is length by height. So therefore, they deduced the area, they learned that the area of a parallelogram is length multiplied by the perpendicular height. They had learned a new theorem in geometry. Now that was problem-based learning. And the same principle was applied in schools like McMaster Medical School, and no, not yet, Maruf. Schools like McMaster, in schools like University of Newcastle and Maastricht, and subsequently in other schools. It took a long time to catch on. Problem solving is different. Problem solving is where you give students the basics, and they apply those basics to work out a problem. The problem depends on the basics. Here, they have to think a little further ahead in problem-centered. Now, the other point you have to make here is that a lot of schools, like the Raymond Gulf University, for example, in the earlier years, they used problem-based. This is the medical school in Bahrain, in which I taught after I retired from Sydney. In that school, they had problem-based learning, but their examinations were based on disciplines. And that created a problem, because you cannot have discipline-based examinations with problem-based learning in the curriculum. Because what students do is then they learn the disciplines. They don't learn in a problem-based way. Okay, they go through the motions of solving the problem that they are given, but then they go back to their textbooks in the basic sciences and learn anatomy separately from physiology, from biochemistry, and so on. So I think it's very important that when you adopt problem-based learning, that you also assess students in a problem-based way, in an integrated manner. And here are some examples of integrated assessment questions. Can I have the next one, please? This is a question that I set surprisingly in Peradeniya a long time ago. And there was, I'll let you read that question. I set that question in the anatomy paper as a long essay question in the 1970s. And there was a big ha-ho at the scrutiny board when the questions were taken for scrutiny. I said, no, I want them. I insisted. At that time, I was acting head of anatomy, so I could insist. I insisted that the question should be set like this, but I'll be very lenient in its marking. And I got the students to think out the answer to the question. They were not used to this subject. You know, the usual type of questions that was set in anatomy, describe the origin, course, and supply of the ulnar nerve, or some such thing. We tried to get away from that and set this type of questions. Here's another integrated multiple choice question, or short answer question. Can I have the next slide, please, Maru?
Brilliant question.
That was horizontally integrated in some way.
This probably explains structural significance.
And the third question, the next one. Another vertically integrated question. This was set in the College of Surgeons in Australia for the primary FRAs, yes. So this is an important point even in postgraduate, when you do postgraduate teaching and examinations, that if you want your students to be able to relate basic science to clinical sciences, it's not enough just to teach them, but, no, not yet, Maru. Not enough just to teach them in an integrated way, but to examine them. I'll now move on to the issue of standards and accreditation. I say this because I I have been involved, as I told you, with the World Federation for Medical Education and with also the China Medical Board in New York, Global Minimal Essential Requirements in Medical Education. Two big projects going on at the same time in the 1990s to develop international standards in medical education. Now, I, for one, was against international standards at the beginning, I must admit. When I was in Peradeniya, as you remember, there used to be an occasional visit by the General Medical Council to the Sri Lanka, the two medical schools in Sri Lanka. It was euphemistically called a visitation, not a visit. And three big shots from the General Medical Council came over to Sri Lanka, and they have wanted to see what the standards were in the two schools. I remember when they came to Peradeniya, Magi Varagunam and I happened to meet these gentlemen, and we asked a simple question: on what criteria do you judge the medical school? And they really had no proper answer. They didn't have criteria. They were judging them as to whether they would fit medical education in, not yet, medical education in the UK. Now, that is one of the reasons why I was against international standards, because I don't think a country should be producing doctors for practicing somewhere else. So I was against this whole area of international standards at the time. But I realized when I worked with the World Federation for Medical Education and with the China Medical Board, New York group for developing standards for medical schools in China, I realized that there were certain things which are common across all countries. And therefore, we developed standards at two levels: basic standards, which all medical schools anywhere in the world should satisfy, and quality development standards, which were additional standards which they should aim to satisfy. We also realized that there was a lot of migration of doctors going on at the time. The global migration with the opening of the European Common Market, migration between countries in Europe, all that resulted in more and more doctors migrating from one country to another, and there was a need for some sort of international standards. What about the Sri Lankan situation? I remember Professor Nilanthi De Silva, who was in charge of medical education at the University of Ragama, accompanied me as an observer to the FME meeting, WFME, World Federation meetings in Barcelona. And she developed some idea of what the World Federation was trying to do with regard to standards, and came back and tried to do something in Sri Lanka about that. Dr. Palitha Abekon, who might be listening, I'm not sure, and Professor Arjuna Aluvihare attended the Copenhagen summit of the World Federation of Medical Education, where the international standards were discussed and ratified, and they became accepted by all the member countries. The Sri Lanka Medical Council organized a symposium of all concerned to discuss the standards in medical education. I was invited to that meeting, and I gave a couple of talks at that meeting, but I don't know the extent to which things have developed in Sri Lanka. I recently read something, a book written by Indika from the Colombo Medical Faculty. Indika is in charge of medical education now in the Colombo Medical Faculty. In that book, he mentions that that they were working towards developing standards, and they hope to have them in place by 2017. But there were some problems between the ministry and the Sri Lanka Medical Council at the time, and it was shelved. I don't know what's happened now. I can't tell you. I have not kept up with developments of standards. Some of you might be able to apprise us of that. The last issue I'd like to get on to, or not the last one, but the last, is the privatization of medical education. Can you go to the next slide, please, Maru? Now, another student of mine, Shena Zelius, from the Middle East, in 2010, she did a study of private medical schools across the world, and you can see the number, the proportion of medical schools across the world, but not the number, the proportion that are private. Philippines, 84% of the schools are private medical schools. Whereas Sri Lanka didn't have one, China didn't have a single, France didn't have any, and Canada didn't have any. Now, 12% of the Australian schools are private, and only 1% of the UK schools is private. Personally, I'm not against private medical education. Any school, if it can produce doctors for the benefit of the country, whether it be public or private, should be allowed to produce doctors. There's no reason why they should not. However, in Sri Lanka, we've had two problems. And we didn't learn any lessons from the first problem for the second problem. And the second also became a problem. The first medical school was opened, if you remember, it was called the North Colombo Medical College. And it started in Ragama. And it started as a private school. If you remember, Professor Viswanathan, who was obstetrician, was the chancellor or the dean at the time. And they did not have clinical facilities in place when they started. And by the time the students reached the clinical years, they had to be posted to hospitals, the government hospitals all over the place. And that didn't succeed. Now, the lessons from that were not learned when SITEM, or the second private medical school, was opened in the South Asian Institute of Technology and Medicine, which Dr. Neville Fernando started. He opened the school. At the time of that opening, I was asked by the Forum for Medical Education in Sri Lanka to give the foundation talk, and I went over and gave the talk on my views about private medical schools both around the world and in Sri Lanka. But unfortunately, it was too late, because by then the government had already approved the establishment of SITEM with the proviso that by the time the students reached the clinical stage, there would be clinical facilities in place. Of course, that did not happen. You can't produce clinical facilities in 2 or 3 years. It did not happen. Students did not have hospitals in which to go and study clinical medicine by the time they came to that stage. And they were left in the lurch, and those students are roaming around all over different countries now trying to finish their degrees. We have a couple of students here as well. So my point is that the licensing body, which is the Sri Lanka Medical Council, should undertake pre-accreditation visits like the Australian Medical Council does, to ensure that all facilities to maintain adequate standards are in place before students are admitted to a medical school. a pre-accreditation visit. And those facilities should include both basic science and clinical science. The Sri Lanka Medical Council must be the body that accredits the school in which those it grants permission to practice in Sri Lanka are trained. It is their bounden duty, it is their responsibility to undertake that accreditation. When it comes to postgraduate education, it is the responsibility of the postgraduate bodies to ensure through continuing medical education and continuing professional development, the standards of each specialty are maintained. And that is my view about the schools and standards and accreditation. The last topic I want to deal with is online learning in medical education. With the COVID pandemic, this has become a necessity. Can I have the next slide, please? Dujipa Samarasekar, Professor Dujipa Samarasekar from the Singapore Medical School, very recently, that is, I think January this year, wrote an editorial in the Asia Pacific Scholar. He is heading that setup there. He wrote a very good editorial on the effects of the COVID pandemic. Personally, since the COVID pandemic started, I have not kept up to date with developments in medical education or with the literature. As you can see, I'm advancing in age as well, and memory is not all that it used to be. So I don't claim to have followed the literature in this field, and I don't want to comment on that since I'm not familiar with the literature. But I looked at Dujipa's paper, and these are some of the things that he identified as the on-site learning is prevented. If you have only distance learning, you can't learn on-site. And we spoke about the physical environment earlier, a lack of access to clinical training sites. There's less interaction with faculty and peers. Advantage is increased online learning, and students undertake online learning. But there is also the psychological effect of student isolation. And I've seen some of the students here in Australia, some of my friends' children who are suffering from this, that they are isolated. They don't mix with other students. The new assessment methods have been developed as a result of this, and faculty is forced to develop distance learning programs. As I said, I don't know about this, but I'm sure many of you are familiar with the situation, so I'll leave it to you to discuss this particular area. Thank you very much for your attention. I hope it hasn't been too long. I tried my best to keep myself from falling asleep. I hope you didn't fall asleep. Thank you.
Thank you very much.
Very nice.
I have difficulty calling you Raja. I still
Raja or Banda, whatever you want. If there's another Banda, so say Raja.
I know, but I have such respect for you. There is a wonderful and informative and interesting history, and also the developmental thing. And I want to open this for question. But can I ask you a very broad question, which I have grappled with when I was an intern in Sri Lanka and so on. How does, I mean, you looked at the methodology of learning, and certainly, integrated learning is the way to go. I had a grandniece of mine studying in Ireland, and her whole learning was integrated learning, and I thought it was excellent, taking a disease process and learning all the things. And even your question about how does a infant get the erect posture and this the structure, I thought was a brilliant question, because that's very relevant. But my question is there an attempt at taking the multiple forces that impact on the content of medical education and relating to see what social good comes out of it? In other words, social good. For instance, you take, for instance, Sri Lanka. Does it really meet the need of the populace like the poorer population and the number of people who are not there. And I'm particularly talking about two things. Number one is, I was a fan of in the 60s on the barefoot educational process that happened in China, where medical education was democratized and sent to a lot of people. And that brought about a lot of good public health effects, or the type of education there in Cuba, which was more directed to the needs of the people. Has our medical education become too elitist? And is it too specialized?
I can't tell you what it is now, but certainly three medical schools try to avoid that. And the three I mentioned are Colombo, Sri Javardhanapura, and Raghava. Gaul tried. I don't know to what extent they succeeded. Peradeniya, surprisingly, where medical education in Sri Lanka started, Peradeniya, for a long time, did not progress towards this idea of meaningful and relevant learning. They did it for the assistant medical practitioners course, but not for the medical course. The point is there are vested interests. People want to maintain their departments. They don't want to see their departments or the power of the department go. This happened in Colombo as well, and I can mention some departments where this happened, but fortunately the deans like Nande and Nandadasa Kodagoda and Lalita were quite strong, and they managed to see it through. So I believe, I'm not saying all learning should be integrated, but I do believe that learning has to be relevant and meaningful in whatever way you do it. And for me, the best way of doing that is through integration, either through those methods that I told you, or through problem-based learning in some way. The three schools in Australia which tried it at the turn of the century were Sydney, Adelaide, and Newcastle started it, but Sydney, Adelaide, and not Adelaide, Flinders, and the University of Queensland, they adopted an integrated curriculum. As far as I understand, they are still progressing and they are doing quite well. I think if we don't make these attempts, we will stagnate. We'll just be in the same thing, doing the same old thing over and over again with making the same mistakes. So to answer your question, I think Sri Lanka, as we all know, Sri Lanka has been at the forefront of medical education in Southeast Asia and South Asia. We've always prided ourselves on the standards we've set in Sri Lanka in medical education. We can't let those standards fall while the others are moving ahead. Take, for example, the Arabian Gulf University. They've just, I've just heard, this is what the Arabian Gulf University in Bahrain. That's where I went after I left Sydney, retired from Sydney. I've just heard this just last week that they've just got international recognition because they've got now accreditation for that medical school. If we don't do something in Sri Lanka, and even if we don't pursue international accreditation, we must get accreditation of our schools. And in this day and age, the only way to get accreditation is through developing these new trends in medical education and not being stagnant, what it was. Stagnant in what it was in the 20th century. I don't know whether it answers your question, Kanya.
Thank you, Banda. Any other questions? Any comments, please? Verita is one of our professors.
I have a question.
Yeah.
Ramachandran, I just want to ask you, in the present juncture with all this online learning, what is the place of artificial intelligence in this? because in Americans health program, they're using to diagnose patients and everything using AI. Now, it is a question of time when this will permeate into educational system. In Australia, they're using in schools now. These are AI system. What is your view on it?
Are you asking me?
Yes, doctor.
I must confess that I know nothing about it. So I'll leave it to someone else to answer.
Can I make a comment on Vikramachandran's as well as I want to ask Raja? I think knowledge.
Why don't you answer? Why doesn't someone else answer that question, Maru?
I'll answer that question as well. That's what my thing is that there is a continuity of undergraduate to postgraduate, and this is being made easier by the intervention of education systems that are online and artificial intelligence. I think if it is properly integrated, somebody who wants to become a surgeon, he will concentrate when you're doing his basic dissections. He will concentrate to identify structures and things like that. And somebody who's going to become a medical person, he'll concentrate on his pharmacology and pathology. And, you know, there is a sort of integration that is possible. And eventually, some of those people at the bottom of the screen are some of my mentees. They have been my mentees and now they are my colleagues. And I have been teaching them at the postgraduate level. And I found if you have an integrated information system that is available, and today our meeting is possible because of the COVID, because during COVID, the Zoom became a very important thing. And we were struggling to meet together. And now we are meeting every month. And we are able to produce very beautiful events like what we are having today. And we are able to meet you and have your rich knowledge reinstated into us. I think there is a place for us to understand how we are going to expand using digital technologies to improve information management, which is continuing education as well.
I have no doubt, Maruf, that is the way of the future. I have no doubt, except that I must claim ignorance because I have not kept up to date with the developments. So I can't profess or I can't pretend to comment on that. But I have no doubt that that's the way for the future. Remembering the possible disadvantages as well at the same time, not only looking at the advantages. To me, the biggest disadvantage is interaction.
Correct.
I think interaction
the qualification after sitting with the computer and say, I have qualified.
Yeah. I mean, interaction with the computer is not the same as meeting even this meeting. If you were a group assembled together and we were together, that interaction is far superior to the interaction we are having now. And I mean, but undoubtedly this might be necessary in the future. It might not be possible for people to be meeting regularly.
Thank you, Dr. Mandanayak. I think I think Benita had a comment and a question. Before that, I just want to interject something of interest to this group. I think in the photograph that you showed, the second photograph of the early students in Manipai, those 6 students, one of those was Bobby Amarasinghe, who's a batchmate who's not here today. His grandfather or great-grandfather, he was one of the 6 students of Samuel Green. And Samuel Green also found that those early students were leaving the country, leaving Jaffna to go and work elsewhere. So he decided to teach them in Tamil. He did what the Swabhasha in Tamil.
Is what? Tamil.
To teach his students in Tamil. He have education in Tamil, and he translated books, Gray's Anatomy and various books he learned in Columbia University into Tamil. And they're still available and it's in the public domain. But interestingly, Bobby's grandfather was one of them. Now to go forward, Bobby's son is into this artificial intelligence. He's a doctor who has had a computer program at a company that has brought all the data that is available from all the electronic medical records all over the place. And he has all this big data and he analyzes, and he has a system by which he can predict outcomes. So he has a system by which every patient in the Dallas hospital where he works is hooked onto his software. And they warn the doctor that this patient is going to get a cardiac arrest, this patient is going to be readmitted, this patient is going to be doing this. And that's artificial intelligence in action. And they predict and take action to prevent many of those things happening. But that's just a point of interest there. The lineage from Bobby's grandfather to his son, who's now using AI. Interesting point. Yeah. Sorry. Yeah.
By the way, I'd like you to look at this book. I don't know if you can see it. It's called, it's the other way around, but it's called 19th Century American Medical Missionaries in Jaffna, Ceylon, with special reference to Samuel Fisk Green. This was published by Thiru Armugam, who's a classmate of mine at St. Thomas's, and he's an engineer, retired engineer, and his wife Malini is here with us at this Zoom meeting. Malini, would you like to say something about that?
I have that book at home. I read that book.
Yeah, it's a great book.
It's
it
a
has
great
all
book.
the about the first medical school in Jaffna.
Malini, you'll have to unmute yourself. Unmute by going to the left and click on the microphone.
Yeah, the interest my husband had, not because he's married to a doctor, but he found a fundamental book written by somebody else about Fisk Green, and my cousin in Kuala Lumpur, Dr. Professor Somasundaram, gave him that book to read, and that created a dying interest to find out more. And I helped him a little in identifying some sections. But the beauty of it is what Raja said, or no, what Karunian said. He was, Green learned Tamil to translate medical textbooks. The reason was he wanted to create doctors in the north to help the people in the north. But what he found out was the moment they graduated, they left because they were earning more money elsewhere. And he wanted to keep them in the north to serve the people there. And that's why he changed the medium of education to Tamil. Those books are still used in India by the medical schools because they were classic. For me to imagine Gray's Anatomy being translated into Tamil is unbelievable. Even I'm a Tamilian, I don't think I can translate even one sentence. But this man studies a language, a foreign language, and that was his mission. And some of the words were not available, so he coined them to make it worthy of understanding. Anyway. My husband has got still some books, so if anybody wants, you can mail me or whatever. I'm happy to.
Personally, it's very nice to meet you, Malini, because I had this book and I've told about this book to many people. It's an excellent book. Do tell him that. Yeah.
Thank you.
Yeah.
Kailas Somasundaram, by the way, Maruf Kailas Somasundaram was the dean in Singapore at one time.
Yeah.
He was a year senior to me in medical school, and he was a surgeon.
And his brother was a neurologist who came to New York and was in Brooklyn.
His elder brother, yes.
An elder brother. And I knew him. He was a much respected neurologist. He passed away and he was loved by his teachers.
I didn't know that.
Yeah. He passed away a few years ago.
I just want
with him in New York. Yeah.
I want to make just a single comment on the dark ages of Europe. I think people studied Arabic. Actually, Arabic medicine has gone into Unani medicine now, but lots of those information that is available is still available in India, because in India, Unani is a fairly widespread medical system. And I found when I attended one of their conferences, there were lots of interesting information that they have gathered from the Arabic language. And at that time, the whole of Europe started learning Arabic because of the presence of Arab forces in the east part of Europe. And they also contributed quite amount of information to medical information.
Thank you. Thank you.
Yeah.
Melita, you've been
Thank you
quiet.
very
Melita.
much. I just wanted to say to Raja Bandaranaike, I don't think you will remember me. I was one of the quietest person in your class when I was studying. Only now I have found my voice. So I thought I must firstly thank you very much for your very, very excellent talk. And I take 2 words from that. That is teaching, or even as a psychiatrist, and particularly as a child and adolescent psychiatrist, when we teach parenting skills, one of the things I learned 2 important words, which were it has to be meaningful and it has to be relevant.
Right.
For that, I thank you for giving me that information today. And secondly, I'm sure all of us who was in the 1966 batch at Colombo faculty will remember Pat Curry. I remember his talks, which he said before we went into doing clinical medicine rests on a tripod. One arm is anatomy, the other one is pathology, the other arm is physiology. And he said very clearly, if you can put all these 3 things into any problem, you can be able to tell us the signs, the symptoms, and equally the treatment that needs to go. And that way, I think we were taught, I always was very proud, our teaching was really absolutely fundamental. But once I had the courage to ask a professor who I think was, why do you ask about what is the blood supply, what is the nerve supply, what is the action of every muscle in your body? Am I going to use that in my medical practice? And he said something which I will never forget. He said, if someone comes with a pain in their big toe, are you going to tell them, I didn't learn about the big toe, so I can't treat you, and send him away? And I think our teaching was superb. And when we were all able to pass our PLAB exam, I didn't have to do the PLAB exam. So I want to know your views, why these schools, we had the ECFMG and the PLAB exam. What are your views on these exams that were set by foreign countries for us to practice in their countries? Have you got any views on that?
Raja.
Well, thank you very much for I'm glad that you carried away 2 words from the talk, which is very good, meaningfulness and relevance, and you can apply it in your work in psychiatry. That's great. But there's no doubt there are 3 major legs on which medicine stands, and I agree with Pat Curry on that. If you have those, you can work out anything. But I think the way they are taught is what matters. And the problem with Pat Curry was that he taught pathology as pathology.
Right.
He did not teach pathology as applicable to clinical medicine. That was lacking because he was a good teacher and I learned from him. But at the same time, that he lacked that ability to relate the pathology he was teaching to what was happening in the clinical field. And I think that's where the problem. I'll give you a nice incident. When I went up for the primary FRCS in Colombo, primary FRCS, we had 3 interviews, and one was in pathology, one was in physiology, and the other was in anatomy. Anatomy and physiology were okay. But when it came to pathology, Pat Curry asked me the question, I was at that time a demonstrator in anatomy in the anatomy department. He asked me the question, what do you know of chronic inflammation? And I knew what chronic inflammation was. And he asked, can you give me some examples? And I gave examples of chronic inflammation. The third question he asked me, and then I mentioned, he asked, what about sarcoidosis? I hadn't mentioned sarcoidosis, although I knew it, I hadn't mentioned it. He said, yeah, that's a chronic inflammation too. Now tell me all you know about sarcoidosis. And I knew exactly 1 minute's worth of sarcoidosis. And I mentioned what I knew. And he kept looking at me, and I kept, for the rest of the 15 minutes, we stared at each other virtually without anything happening. And Professor Vass happened to be there observing this. And after that 15 minutes, he had gone back to the anatomy department. I think Banda is gone. But fortunately, the other examiner was Digby Chamberlain. Digby Chamberlain, who was the president of the College of Surgeons, he realized what had happened. And he started asking me questions all over the place in pathology, most of which I could answer. And lo and behold, I passed in pathology. And I passed the primary. But that's the sort of person Kure was. He wanted words to come from your mouth. And he was not a good teacher in that sense. He was, and certainly not a good examiner in that sense. So I have my concerns about that, Shanti. What he said is quite right, that there are these cornerstones of medicine which have to be grasped before you're able to practice medicine. But he should show that in his teaching as well.
I think I agree with you wholeheartedly, but I think we also have to change with time. And I think we are changing with time. And as I think Karunin and Maharoof said, the teaching on Zoom and so on, everything has its advantages and disadvantages. And I think one of the things I know during the COVID pandemic, treating people who had suicidal ideas and everything over the phone was so difficult, we couldn't see. But as you said correctly, we had to move with times. And Pat Kure was, we would say he was in the old way of thinking, but nowadays people think differently, and you brought that into focus today. For that, I thank you very much. And thank you very much, and lovely to see your face, and lovely to see your brother's face as well, Ranjit. I did go and stay a few days when I went to New Zealand. We had a good time there too. Thank you.
Thank you, Shanti. I want to let
go in there next week.
I want to excuse me.
Dr. Bandaranaike, you have
Yes.
not changed a bit since you lectured to us in medical college. You look the same. There's no change at all.
Thank you.
You look the
I
same.
want to let Benita has been wanting to ask a question. No, I cut her off. By the way, I want to just make Benita, before you start, Benita's photograph is up in the common room. Benita is the only person who's photograph is up there. Oh my gosh. Okay, Benita, go ahead.
Just to thank you, Dr. Bandaranaike. Thank you very much. Because Raja, yes, I know, because it reminded me of the medical student days. And anyway, it's just to be, I wanted to give you a laugh because I don't know whether you could remember in the second MB, I was one of the most boisterous one or this one. And one day you chased me out of the dissection room. Right? That's why I was chased out by you. And so, and this was, you were studying for your primary. And I was, as usual, with a loud voice, was disturbing you. And you chased me out. So I wanted to laugh about it. Anyway, the one of the things that before, what Raja, what you said was before the NCMC private medical college started, remember North Lanka Medical College started.
Yeah.
That was the first one in the north.
Yeah. Yeah.
And when Minister Hamid was there, and Steve, and the government wanted, and Stephen Hamid went to North Lanka to assess the medical college to see whether that's it's a good one, and they actually said that should be recognized, and that was told to the SNMC at that time. And but anyway, political, as usual, the students' union knocked it off, and that went off flat. After that, only the NCMC came up, and the third one of that was, and the site team. Now, what you mentioned was that to everything in place before it could start. Correct, but they had the lectures going on, and they had everything in. Ragama had his hospital. Site team had his own hospital was on. But you see, there are a lot of vested interest which didn't want that to happen. That's why the 0-0 that you said on private medical colleges, it is not because, I don't know, I may be wrong, not because the hospital, there were hospitals that were with the, now, Neville Fernando put up that big hospital that was functioning.
It was too late.
But they knocked it off.
That was too late. That was later.
No, it is
by the time the students,
started off.
by the time the students came, the hospital was not ready, Benita.
NCMC, 6 batches, they were really passed. But now, no, okay, we didn't have it, assuming. But remember, everyone, the best students are the best consultants in Sri Lanka now are from the NCMC, not from the state. Even though I am from the state, I'll acknowledge that every best surgeon and the physician in the sector in Sri Lanka are from the NCMC. And that, the accusation was money bought them because the parents were doctors and somebody else, that they were all came in through the back door. But now it proved it wrong, that private education itself has its own advantage. Maybe, you know, whatever that is there, but allowed the students, they are also students, and government, our fellows were also students, all are students. And
I agree with you. 6 of those students who were displaced by the NCMC closing down came here to my medical school in Sydney. And I remember their names as well. And the dean of the medical school here asked me to help them and to be like a sort of a godfather to them when they were here, so that they could acclimatize to the situation and all that. And we used to have them home regularly and take them out occasionally and so on. They turned out to be very bright students, and one of them topped the batch at New South Wales Uni. So they undoubtedly they were bright students. That is true. But the point I'm making is that they were left in the lurch because they didn't have a place to go to. They had, some of them had to come here, and that's not satisfactory. And that's why I say it's important to have all the facilities, both basic science and clinical facilities, in place before a school starts. And that can only be achieved by a process of pre-accreditation by the SLMC, as is done by the Australian Medical Council here. No school here can start unless they go through a process of pre-accreditation. And only then are they allowed. We had several schools opening here recently, but they all went through pre-accreditation.
Thank you. Anyone else?
Yeah,
I thought I saw Shenaz Ilyas
yes, sir.
is here.
Yes, sir. Yes,
Yeah,
sir. Good evening. Can
is.
you? Good evening, sir. Can you hear me?
Good evening. I can see your photograph. I can't see you though.
No, sir. I'm outside, so I'm listening to you. It's such a pleasure to see you.
How nice! How nice to hear you. Shenaz is the one who did the study on private, I told you, private medical schools. She was a master's student of mine, and she did that study on private medical schools.
Thank you
How
so
are you
much,
doing,
sir. Fine, sir. Thank you so much. Just wanted to comment something about the online education. I think I may be one of the younger Zoom member here. And the recent experience with the online classes, because I'm a pharmacologist, I have around 20 years of teaching experience. And the online classes, as far as I'm from India, as far as India is concerned, we have school graduates who enter med school. So the level of maturity and involvement with medical education is not that much for these school entrants. This is the graduate entrants in the rest of the world. So online classes, online teaching is good only during the COVID time. But as Sir has mentioned, and he always has mentioned, the interaction between the students and the teacher is a must, especially when you have these, should I say, immature students who are with us. I think it's the same in Sri Lanka, where they have the school, after high school, they enter med school. So online teaching is okay as far as the theory to some extent, but we have these batches who are coming out with very less clinical knowledge. And it's scary because eventually these batches are going to treat us when we become old. And they get away with the fact that they are a COVID batch. Everybody understands when they say, yes, I'm a COVID batch, because clinical training, even the basic sciences training was really at a low level. So that's my take on that, sir. And thank you for quoting me about the privatization. You have always been my mentor. It's lovely to see you, sir. Thank you so much.
Thank you, Shana, sir.
Hi, if I may
Just
say,
to answer, just
hi.
to comment on
Sorry.
that one comment I'd like to make. We did, when I was in, before I went to Bahrain, when I was here in Sydney, my research assistant and I, we did a longitudinal study, a cross-sectional study across the medical school years of the students. And we found that the first-year students were far more interactive and far more able to communicate with each other than second and third-year students. And we attributed that then in that study to the paper has been published in one of the journals in medical education. In medical education itself. We attributed that to the teachers. The teachers made the students in the first year, made them less interactive. And when they came to the second year, they had lost that ability to interact with each other, comment on. They were far more, first year students were far more able to disagree with their teachers or voice their opinions than second and third year students. Now, this may vary across countries, so I can't generalize from that, but in Australia, that was what we found.
Agreed. Any other comments from anyone?
Yeah, if I can speak for a second.
Sure, sir.
Yeah, I was first of all going to thank him, Banda, very much for this really great talk and the history, which I think I had never even thought about. So it was great to know. And also, I think I was just a very lowly medical student, but we lived down the same road in Dehivala. So I was Sarojini Abekon at the time. And like I said, I was a lowly medical student and you were on the staff already. Of course, Banda was in my batch. And I just wanted to say thank you, and just a personal thing that I remembered about the two of you. That's about it. So thank you again, and it was a pleasure.
Nice to hear you,
Thank you, Saro. Next time I'm going to ask you to talk on the definition of a lowly medical school.
Lowly medical student.
Some of the bachelors, they knew that you were a lowly medical student.
Pretty lovely medical student. I was your batchmate. So that's by the way,
yeah. Thanks, Raja.
Thank you very much.
Remember, I think I was in the second batch that joined you for medical education in this one for assessment. I came with Colvin, Saroja Senior, Geeta.
Yeah,
Geeta
Colvin also
yes,
came.
And that's right, in Australia. That's right. Thank you. And I can remember the lovely dinner we had at your place. Thank you. For Chandrani and you for hosting us. Thank you.
Any other questions?
That's right.
Dr. Moon, you're talking? No. You're muted.
Hello.
Tuba.
Yeah, my name is Mona Sheikh. I am the Vice President of Saudi Society of Medical Education. I had the privilege of learning from Prof. Raja and AGU in my Master's of Health Profession Education. And I can't tell you, like, he's one of the best teachers I've been exposed to. And I've been exposed to teachers from all over the world, if not the best at all, of course. Now, the issue is that we learned a lot from him, and whatever we learned was kept in long-term memory. But it's not the information as much as the ethics. He's really a role model. And I had also the privilege of hosting him as a consultant for 1 month in our college, King Faisal University that time. So what I wanted to ask Prof. Raja, and please don't get me wrong, I am an advocate of innovative methods of teaching because I felt the traditional way was a little bit losing the goal. So when I joined the physiology department, they asked me to give a seminar, and my seminar was about innovative approaches, all these SPICES model, all these trends, what Newcastle, McMaster, McGill, all of these, and I was an advocate for them. But I'm just, rethinking the whole thing. Do you think integration, I mean, if we have a smart learner, and this is what we did when we went through the traditional program, we used to link information, anchor things together between physiology, biochemistry, and then because we kept this in long-term memory, we anchored it also, or we used that to apply to the cases we saw in medicine, surgery, and we had no problem with that. So, I mean, if we are admitting smart students, and they're supposed to be, should we really say, no, we are going to integrate for them, we are going to give them the problems? Or should we let them just face real life based, that they will, their mind, if we rely on the learning theories that you taught us, the cognitivist and constructivist, and now they have newer ones, shouldn't the learner himself do that in his own mind? Do we have solid evidence that integration and problem-based learning is actually making a difference? Thank you.
Yeah, Mona. Nice to hear you, Mona. It was, I agree with you entirely. The learning that takes place through techniques such as problem-based learning or integration should be in the learner's mind. It's not for the teachers to be integrated only. The teachers should prepare the learning session in such a way that the learners learn to integrate by themselves in their own minds what they are learning. That's very important. And that's the essence of problem-based learning. If you go to the Arabian Gulf University, for example, students are in a small group, the problem is given to them, and the tutor does hardly anything. In fact, there was a situation where in the early years, I heard before I went there, this was when the college started, where tutors were sent from the University of Newcastle. And Newcastle at that time had the idea that anyone can be a tutor. And the person they sent as a tutor, one of the persons they sent as a tutor was in fact a lawyer who knew nothing about medicine. He went there as a tutor and he was tutoring a group. Of course, the tutors are prepared to some extent before they go and tutor a group. And he was tutoring a group, and the students, you stay with the group for a while, you don't, for at least 2 or 3 months, you stay with the same group. The students very soon, his group very soon realized that this guy didn't know any medicine. And then they started deliberately saying the wrong things. And he wasn't able to pick them up. So while it is important that the students do the integration, it does not mean that the facilitator of the group or the tutor does not know anything. He must be fully aware of what's happening, but leave it to the group and then correct their mistakes when they make mistakes. That is the essence of problem-based learning, not just give it to the students and then take the students through the problem. So the integration is taking place within the student's mind, not by the teacher integrating it and presenting it to the student.
Thank you. Thank you. Now, I want to also, before going forward to Padmalingam's question, thank Ranjit for making this talk possible. Thank you, Manda. And you are, I know, in the middle of the night, we're keeping up, but thank you.
Where is he? I haven't seen him.
Karunian, yeah. Thank you, Karunian. Can I ask a quick question, which probably you can answer or Vicky can? I've heard rumors that Jaffna, the medical school in Jaffna, have considered admitting some private students to earn more income. So can you tell me the story there? What's happened?
I don't know anything more than, maybe Benita might know, more than that. There are some, even Lalita, I think when she was dean, mentioned this to me. Some of the medical schools are trying to get some revenue in the difficulty in revenue stream by admitting foreign students on a commercial basis, giving some of the seats to them, and that's all the extent I know. And I think Lalita actually, when she was dean, once mentioned this to me when I was trying to talk to her on something else. So that's the extent of my knowledge on that. Benita, do you know anything more on this?
There is, you see, when we were, at the time when we were there, that the government allowed a percentage, 1% or 2% of the students to be foreign students. So we used to get students from Bhutan, Nepal. They used to come and study, and they had to pay. They had to pay, and they were in the state school. And actually, the government of, say, Maldivians or Bhutan, they paid. And it's about $7,000 per annum, like that, for the 4 years. And they got the Colombo degree and went. And that's, I think that was allowed. So this, I saw that advertisement, the Jaffna medical faculty saying for $12,500 foreign students they are willing to take. But the basic requirement is they should abide by the requirement of the A-level, whatever the standard cutoff point, and whatever the credits and whatever that is expected across the board. There are no exception. But there is a quota that is allowed for each university to take in. And that has been there when we have taught students. And who had for years in the medical college they came. So then it, not that we had, and after about the latter part of it we didn't have. And someday I saw that advertisement in the Jaffna one, but I don't think it is something that is new. It has been there.
It's not new.
It's not new. It's not new, because that's it is not say 12,500 is peanuts. For a dollar for to teach. Whereas now, when we say when we go on a training, for each year you go out, you are bonded for 3 years. Of you have to come back and serve 3 years in the university. So similarly, and about $1 million rupees, I think, on the students when you get an MBBS and postgraduate training, and if not for up to the MBBS, it's free. Postgraduate training, where if the PGIM pays, and if the person wants to get out and work in another country, you have to pay back. And that is most of those days people used to abscond, but now they pay and go off. And it's not a major amount. It's maybe about a couple of millions, but they pay and leave. So it's not I don't think that's, I know there was a lot of heat wondering why they are trying to get some money or something like that, but I think it's in the system.
Okay, thank you. Now, Padmalingam was we got to listen to Padmalingam. He's a friend of Joe Biden. So, you're muted, Padmalingam. You're muted. He's muted. Padmalingam, you're muted.
Can you unmute yourself, Padmalingam? Click on the microphone on the left corner, left bottom corner.
Padmalingam's daughter and Joe Biden's son went to the same school. They were classmates. So we got to be careful about him.
That's funny.
Ready?
You're
Muted.
we can't hear
You're
you.
muted.
Click on the microphone, a picture of a microphone on the left bottom corner. Click on it and that will make you come in. Ready?
It's possibly in the left corner, bottom corner of the computer. On your left-hand side.
On the screen.
On the screen. Padmalingam, can you hear me?
I'm calling him on the phone, he's not answering.
Down, look down.
Left corner.
Part of our perceptual issue.
Yeah.
Okay, anyway, we'll wait for him. Okay, anyone else while Padmalingam sorts it out? Padmalingam, at the bottom corner, left-hand corner in the screen, go to the left. Boy, this modern technology. Anyway.
Maybe AI. Karim,
Any
can I
other
say
comments?
something?
Anyone else?
Karim, can I say something about AI?
Sure, yeah.
Of course, I've known Raja a long time, and I've also known Ranjit. I was called JI in school, not the correct correction. As a radiologist who's retired now, I think AI is amazing because as I know how many times we've been shown little pulmonary nodules and you can't pick it up. And the AI shows you 99% of the time. Also reading like mammograms. Example, we are now reading digital mammograms. And I was very proud. Sri Lanka has digital mammography and nobody goes. Anyway, this stuff is amazing. But we were told that in about 10 years, we will need 40% of less radiologists. So lots of us were not going into residency. That is not true anymore, but it's still less. That's number one. Number two is we still will need these doctors, but in a different way of guiding the whatever is done. Let's look at your patient. Your patient comes to a big hospital. You get a CT scan done, and the scan is read in the evening by a radiologist, and the report goes to your primary doctor in 3 days. That is bad. That is very poor quality. With AI, you can go to a department, you can get your scan done in 15 minutes, you can have a report in 10 more minutes, and you'll have a report in your hand in less than half an hour. That is good medicine. And I was talking about, they were talking earlier, one of the doctors about like doing things online, things, all this stuff. I think there's a big place for AI in medicine, but we should not get crazy and say AI is going to take away everything. Let's be honest about it. All of us who are everywhere in Colombia and Pennsylvania, most of us who are here, we love our teachers. Our teachers are the ones who taught us. And when I loved anatomy and I was fairly good. But the thing is, when I came to my residency, they couldn't believe that we knew this much of anatomy, because suddenly I learned MRI on the job while I was getting trained. I learned CT scanning, and we could not believe the beautiful anatomy that we were shown, but then everything goes back to our teachers. Patkure was a pain in the ass because he's a very bright person. He's from my next door. I'm from Oroto, he's from Panadura. So he is, but his problem was the arrogance of all our professors. How many of your professors knew your first name? I counted the number of professors who knew me as Jayasari, there were 7 or 8, and some of them are amazing. Example, Viswanathan, I mean, unbelievable. What anatomy and what embryology. And he called me one day and said, well, how did you were doing sports and all this stuff, but you screwed up your whole, your paper on embryology. I said, sir, I didn't study enough. And I just want to make it short. Anyway, that's my talk on AI and my talk on our teachers. I do not think you can learn medicine by doing things online. You got to have good teachers right around you. They got to guide you. But I think, thank you very much.
Thank you, Jayasree, and always a pleasure.
One short comment, Karnian.
Dr. Banda wants to say something.
All the digital devices, I think, have now integrated AI into it, and the latest ultrasound machine, 3D ultrasound machine, has even evaluates even reports that are done by radiologists in order to appropriateness of the reports. I think it's going to become a part of the digital imaging services of the world. Yeah. Thank you very much for that.
AI in the modern world, we deal with AI without knowing we are dealing with it.
That's right.
When you go to the EMR, electronic medical records, and you put a diagnosis, immediately all the possibilities and what has to be done comes in there. And, that's AI. How much and how intrusive and how much it will replace is yet to be seen. But I think substantial amount of information will be coming through AI. And I also had a friend of mine's son who is a computer guy who showed me modeled a thing by which a non-medical person can, by asking questions and going through algorithms, very much come to a diagnosis. So, so he was saying doctors are going to be relevant because you can make diagnosis and even treatment. I don't know, but anyway, the essentially AI uses human knowledge to electronically use it, and it's going to be part of our life going on.
Raja has already talked about that relevance and importance and integration. All this is in AI.
Yes,
without that, AI will not exist. That's why.
Maruf, can you hear me?
Yes.
Thank
you.
Yeah, I must be unmuted now. Anyway, what I wanted to ask you was, or ask all of you, it was well known that it was quite a difficult task to get into a medical school around the time we were medical students, seeking entrance into the accepted national medical schools. Is it fair if parents have money for some of these new medical schools to admit boys and girls or ladies and gentlemen to do medical studies without that sort of competition that the other people had to undergo prior to the starting of the medical schools? And how many private medical schools are there now? There is one in Corte or somewhere, Neville Fernando, I think. And there are maybe some others in other places.
Maru, can I say something?
There are no private medical colleges now.
In Sri Lanka, there are no private medical colleges. And the answer, Mohanlal, if I may comment on your question, is a philosophical, political, ethical, moral question, and the philosophy of the contract of the people with the state. So I don't want to go into it. But Dr. Bandaranaike, you want to comment on that question? Is it moral?
Mohanlal, it's nice to hear you after a long time. I wish I could see you. Are you still playing cricket, man?
Now I have come to the stage when
balls
and all sorts of other sports. I used to play it till about 4 years ago, but I have had replacement of knee joints and things like that. And I don't know why my photo is banned from Slimo.
No, yeah.
To answer your question, Mohanlal, you asked the question, is it fair? As long as they meet entry criteria, which are the same for all, whether you're going into a private school or whether they're going to a public school, if they satisfy the entry criteria, I don't see any reason as to why they should not be admitted. It is fair. As long as they meet those criteria. If there are no places in the public schools, why not get them into private schools where they can pay? But the admission criteria have to be met. That is, they must satisfy those criteria. Otherwise,
Okay. All right. Any other questions? It's 2 hours since we started, and I think it's the middle of the night for Raja, and we should close up.
it's 1 o'clock in the morning here.
Yeah, and it's Banda in New Zealand, it's the middle of the night. Shall we call it a day or a night or whatever it is? Okay, I think.
Thank you very much, Raja.
Thank you. You know, the next talk. Yeah, the next talk, Maruf put me as my talking on diabetes. In fact, I recently wrote an article on the South Asian heart disease, which I have talked before too, the prevalence and the mechanisms of that. And maybe I'll put that on the Slimo thing just for people to see. I mean, it was meant for public consumption. I wrote it to a newsletter that the St. John's and Tundukuli Girls Old Students Association has in the New York. They publish a very high quality newsletter. I wrote it for that. But maybe that or someone else. Maruf also has some speakers. But if you have any ideas to have stimulating, interesting discussions.
None other than Kumar's son, who is an interventional cardiologist who has done a lot of research in cardiac, and cardiac is a major problem. As well.
Okay, so why don't you get him to give a talk and we'll...
He's willing to do that, but your speech first. It has been going on for some time.
You know, I might travel to Sri Lanka. We'll talk about it. We'll put out a news item and we'll have.
You had to click twice to get to it. I'll try now.
Hello, Patmalingam is in. Hi, Maru. Patmalingam is in.
Go ahead.
And you all here?
We are waiting for you for the last 2 hours for you.
I know. I think I am very pleased that Raja, my biggest handsome teacher about almost 60 years ago, is still there, not sleeping at 1 o'clock in the morning. And Don, the brother, my batchmate, my father being a teacher, I am telling one of our best teachers in medical school is Raja. And I think knowledge is power, and he's a very knowledgeable man. What I could say about human values is honesty, respect, responsibility, trust, caring, and sharing. And Raja has all those good part of his life. And I'm happy that both brothers are doing extremely well. With that said, I think all I could ask Raja is, how does he spend his time at his nice young age?
You didn't see the last picture of the slide.
I want to hear from my teacher.
Yes, unfortunately, until the COVID pandemic started, I was still working. I was still doing assignments, short-term consultancies all over, particularly in the Middle East. And I was traveling around quite a bit doing work. But when the pandemic started, I had to stop because at my age, it was too risky to travel around. And now I keep myself occupied, mostly writing. My wife says I'm cooped up in my study all the time, but that's what I do. I try to do a bit of writing. Just now, I got interested in something completely different from medicine. I got interested in Dickens, Charles Dickens. Charles Dickens, who's Malini, you know about this. I spoke to you. I am interested in Dickens on Ceylon. Now, that's a conundrum which I leave you to solve. One of these days, I will talk about it.
I'll be very interested to know that. I have to say, we all studied Tale of Two Cities when we were in
Yeah, that's the only book I knew too, Tale of Two Cities, because we had to study.
O level. But he's just wonderfully socially sensitive.
Madame Rifaj.
But we'll have the interesting things going on, and hopefully we'll keep it going. And all of you, Malini, and we'd love to hear your husband. I'm an admirer of his book. You never knew me, but I've sent books to various people. So he has historical knowledge, which would have been, I think, useful. But anyone else, all of you, please, you are welcome to come to our meetings. Maruf can send them things.
If you can kindly send your number.
1966 batch. But anyone who wants to join us and have a good time listening to some interesting stuff in a light manner and so on, you're most welcome. Jayasri, one person whom Kumu Fernando was going to get us was this gentleman who knew a lot about the kidney disease in Sri Lanka, in the north central province. Do you know who that is, and can you get him to give us a talk?
I can find that out for you, and
can you
ask my nephew also will. Do you want my nephew to talk sometime?
Something relevant to Sri Lanka too. There was a huge amount of kidney diseases in Sri Lanka, and I might also just share the interest that they did a live transplant, renal transplant in Jaffna 2 weeks ago, and there was a renal state surgeon from South Dakota, town Tambipula. He went and did it, and
no, I don't. I'll find out. I can find out for you.
Yeah. Okay.
I'll call you personally.
Okay. Okay. Thank you very much, all of you, and Raja and Dr. Bandaranaike. I have difficulty still calling you Raja, but thank you very much. And I must say, you look very, very well and very
handsome, like what he used to be.
Thank you very much.
Thank
you, Ranjit.
And thank you all for tolerating me, tolerating my rambling. Wish you all the best.
Thank you, and do
join us. Thank you, Raja. That was a lovely meeting. Thank you.
Thank you. Bye-bye.
Thank you.
Bye-bye. Bye.
Thank you,
Bye, Maruf.
Okay.
Thank you, Maruf. Thank you for organizing.
Thank you. Thanks, Karuni, and thanks all of you.
See you soon, Ranjit.
Yep, see you. It's 3 o'clock here now. I'm going to.
Shanti, good morning. She said regards to you.
Don't worry that your Prime Minister is retiring.
Shanti, yeah.
Yes, she is in Colombo. I spoke to her just about maybe about a couple of hours before this.
Tuba is an obstetrician from Pakistan, and she has joined us. And I think those who are joined and not having their numbers, please send me your numbers, and I will join. I will make you member of the Slimo group. Malini, I think that goes for you as well.
Okay, thank you.
Thank you.
I got the link through Raja, so
yeah, okay, sure, fine.
I would have missed it otherwise. Yeah.
You can send me just your telephone number and your name kindly, and I will add you to the Slimo group, and then Slimo family. Yeah. Okay.
Okay. Thank you.
Thanks. Good morning, good night, good afternoon, wherever you are. All the best.
You look so handsome, Maruf.
Raja.
I'm cutting off.
Okay.
Bye, Raja.
Raja.
Bye.
Bye. Bye, everybody.
Bye.
Okay, I'm going to show you just so you see this button says leave. Now you can't touch it. You have to do it with the mouse.
Sorry, I would like, Maharoof, I'd like to have Malini's number if possible.
Yeah, if she sends to me, but I will ask Raja if you can share it.
Okay, I know her has Arumugam as well. Yeah, thank you. Thank you for everything. Thank you, Raja Bandaranaike. It was lovely to see you.
Raja is gone, I think.
Yes, no, it's okay. Lovely to see everyone.
Muhammad Tawheed. Ahlan wa sahlan.
Hello.
Hi.
Hello, Assalamualaikum.
Walaikum Assalam, Tuba. How are you?
Alhamdulillah. How are you?
Enjoyed this interaction of my batchmates, starting from Los Angeles up to New Zealand.
Oh my God. So you are growing like COVID.
Yes, I am like COVID, spreading everywhere.
Global.
I suddenly realized when I was sending the messages to you all,
Yes,
I think our group on the online learning group in the postgraduate, I think we have a big group. I think we must make into a group and join this group. It'll be a very good thing.
It's a good idea.
Yeah,
Amazing.
so I'm going to send to if you like.
I'm a big supporter.
Good, good. What are you doing nowadays?
Yes.
What are you doing right now?
Right now, I'm doing my private practice.
In Karachi or somewhere? In Pakistan or?
In Pakistan.
Yeah, that's good. Send your details and we'll put you. I'm just building a database of all the people. And suddenly I realized we had so many of our people who are in the MRCOG courses. I sent to them all. You must get them together.
So you are always an amazing teacher. You are really a very big teacher.
No, no.
Teach.
We have this monthly meeting at the last Saturday of every month, usually 1 o'clock. It is, I will send you the details hereafter.
Okay.
So you can invite your friends and join, it will be very good. And eventually we will have some of the talks are on life care, which I did once. And I think life care is a very important thing. And they have called it lifestyle medicine in UK. And I agree with the lifestyle, but medicine, I don't agree. To look after ourselves and the 50 trillion of them, it will be very good.
Okay, it's amazing.
You
it's
look
very good session.
Well and young as usual, and that's fine. Absolutely.
Same here, sir.
Yeah. Luckily, my wife is not in the line. She's off. Hey, Saki Bhai, you missed the meeting. You were there. Ah, right. Oh, that's why. You should put your name. You're part of the system. Yeah. Why don't you prepare a talk on AI in medicine? Oh, you prepare and you and I will present it. Yeah, okay. Sure. Sure. Yes, Sakibai. No, it's much more than that. It's some of the things that Raja Banda said about relevance, correlation, logic. Yeah. Yeah, that's already in. That's AI 3 already has accumulated machine learning. Okay. Let me finish with this meeting and then I will talk to you. Yeah. Okay. Yeah, people are going off, so I just want to say bye to them and then I will call you. Okay, bye. Bye. You should have come and talk. Anyway, doesn't matter now. We will talk about it. Okay. Okay, bye. Okay, thank you, Tuba, Amani, Muhammad Tawheed. Okay, so they're out.
Happy now?
Alhamdulillah. It went on.
Nadia, can you get some